Erythropoiesis takes about 5 to 7 days. It takes about that long to go from the hemocytoblast replicating and dividing to form daughter cells that will eventually enter the myeloid stem cell line, all the way through to the development of a mature erythrocyte. So the earliest cell that we see in this lineage is a proerythroblast. This is now a cell that is determined to differentiate into a red blood cell. And it's going from a proerythroblast to the basophil erythroblast, etc. And it's becoming more and more differentiated along these stages. And in each of these phases, the cell is focusing on making large amounts of hemoglobin. Hemoglobin will be the most abundant solute inside the cytoplasm of the mature red blood cell. We recognize that it is the reticulocyte that enters the circulation. A reticulocyte should not be more than 1% of all total red blood cells. We know that the reticulocyte does not have a nucleus, but it still has remnants of RNA and endoplasmic reticulum. Up until the very last moment, the cell is focusing on making as much hemoglobin as possible. It takes about 1 to 2 days for the reticulocyte to mature into a red blood cell. Why is it important that red blood cells ultimately shed all organelles and lack especially mitochondria? Well, one of their jobs is to transport oxygen. And if red blood cells have mitochondria, then that means they would be capable of aerobic metabolism, which is, of course, the oxidation of glucose to synthesize ATP. And then that would mean less oxygen released to the tissues of the body. So the poor little red blood cells take one for the team. And there's a trade-off for their robust ability to transport oxygen. They are relegated to anaerobic means of making ATP. So that is the reason why they don't have mitochondria. It's so they can transport more oxygen and have more oxygen delivery to the tissues of the body. Hematocrit is the percentage of red blood cells to the total volume of blood. When we measure hematocrit, it is in a heparinized tube, a hematocrit tube. We measure in millimeters the distance of the packed red cell volume, and we divide that by the distance of the entire blood sample in our tube. It's also measured in millimeters. And then we would have a percentage of red blood cells. Again, men will have a higher hematocrit than women because they have more blood volume. But then also the testosterone that they make stimulates hematopoiesis, specifically erythropoiesis in the bone marrow. Hemoglobin concentration is the amount of hemoglobin in 100 milliliters of whole blood. Again, the normal range is about 14 to 16 grams per cent, with the average being 15 grams per cent. Males, of course, having a higher value than females. For every gram of hemoglobin a patient has, there are 1.34 milliliters of oxygen that can be transported. So we multiply a patient's hemoglobin grams per cent by 1.34 to determine a patient's oxygen carrying capacity. On average, there are 20 milliliters of oxygen per 100 milliliters for an individual, and that's how we express the units for oxygen carrying capacity, mil/O2%. And again, the percent means per 100 milliliters of whole blood. Another review of your red blood cell indices, of course. It's very important to have these down like the back of your hand before you start your professional schools, whether it be nursing school or physical therapy or PA school. The MCV stands for mean corpuscular volume. Again, that should be between 80 and 100 cubic microns. Mean corpuscular hemoglobin, or MCH, refers to the weight of hemoglobin in a single red blood cell. It should be about 32 picograms. Another way of writing that is 32 micrograms. That seems to be a more antiquated way of writing the units. Nowadays we just say 32 picograms. Mean corpuscular hemoglobin concentration, or MCHC, refers to the concentration of hemoglobin with respect to the volume of a single red blood cell. So it's a solute to solvent ratio. It's the amount of hemoglobin in a single red blood cell divided by its volume, basically. So that's 34%. Mean corpuscular diameter, or MCD, is about 7 to 8 microns. And color index is basically a visual determination of how red the red blood cell looks. If there's adequate amounts of hemoglobin inside the red blood cell, we give it a color index, or a CI, of 1.0. If there's 50% less hemoglobin, let's say instead of 32 picograms we have 16 picograms, well then we would give the red blood cell a color index of 0.5. We need to review some terms because in a subsequent segment I'm going to review different types of anemia, and we're going to see that with various types of anemias we can get changes in cell size or cell shape. So the term chromasia is going to be an indication of how much hemoglobin is in a single red blood cell. Again, this has to do with that color index I just told you about. If we say that cells are hypochromic, you should instantly be thinking that there is reduced color index because of a reduced amount of hemoglobin within that single cell. Hyperchromasia is really only going to apply with hereditary spherocytosis, and I should caution you with this one. A lot of times students think when a cell has hyperchromasia, it's because the red blood cell is overstuffed with hemoglobin, too much hemoglobin. And really, in the synthesis of red blood cells, you don't get an overproduction of hemoglobin packed into the red blood cell. We'll see that there is going to be a special case in hereditary spherocytosis, but I think you'll see when I get there that it's not from an overproduction of hemoglobin, but rather from a red blood cell that's decreasing in size over time. When a red blood cell is described as normochromic, that means that it has an adequate amount of hemoglobin packaged in it. The term dissociation refers to cells of abnormal size. That means you should be thinking of changes in mean corpuscular volume. When we say a cell is microcytic, that means it's too small. When we say it's macrocytic or megaloblastic or megalocytic, that means those are large cells. Normocytic means it's a cell of normal size. Again, 80 to 100 cubic microns. Poikilocytosis means cells of abnormal shape. We're going to see abnormal shape with a few types of anemia, like, for example, sickle cell disease. Just to remind you that our red blood cell production should be maintained at a steady state. That means the synthesis of erythrocytes should match the rate of removal of the erythrocytes in the liver and spleen. I gave you a bathtub analogy. If you were to fill up the bathtub halfway full and then match the inflow from your faucet to the outflow of your drain, and then leave the water going overnight, your bathtub volume should stay the same. But the next day when you came into your bathroom to see your bathtub, I hope you would recognize that the water molecules you have there in front of you are different than the ones you saw the night before. So there's constant synthesis of red blood cells, new reticulocytes entering the bloodstream being matched with the removal of dead or dying red blood cells. Red blood cells live for about 120 days. There's a reason for this. They don't have any organelles, and they sustain a lot of damage while in the circulation. They sustain a lot of oxidative damage, particularly to their membranes, and this means the red blood cell will be less flexible. That means they're going to get hung up on the reticular fibers in the liver and spleen and be removed by macrophages. More on this soon. Red blood cells have a biconcave disc shape. This is going to increase their surface area, which allows more rapid diffusion of gases, oxygen and carbon dioxide, of course. And this biconcave disc allows them to literally fold in half. You see, the red blood cell, although it is only 7 to 8 microns in diameter, it's still bigger than most capillary beds in your body. The capillary beds have a smaller diameter than that. As such, the red blood cell might need to fold over on itself, as shown in this top right picture. Red blood cells are membranous bags of hemoglobin. That's their most abundant solute in their cytoplasm. There are other solutes, of course. There are enzymes and other types of structural proteins, but hemoglobin is the most abundant, and it's necessary to transport oxygen and carbon dioxide. If you were to make a tiny little period at the end of a sentence, in that volume you would have about 5 million red blood cells per microliter. And it's just so remarkable that we would have 5 million red blood cells in that tiny little microliter. They are truly the most abundant cell type in your body. It's time to now talk about the synthesis of hemoglobin, the molecule itself. Hemoglobin, the molecule, is actually a combination of 4 smaller polypeptides. The adult version has 2 alpha chains and 2 beta chains. And I'll remind you that the 2 alpha and 2 beta chains are products of gene expression. They are proteins, so they have to be coded by a gene. The genes for the alpha subunits are found on chromosome 16, and the genes for the beta globin chains are found on chromosome 11. There are 2 genes for the beta chain on chromosome 11. There are 2 on each homologous one on each homologous chromosome, and there are 4 genes that code for the alpha gene, and there are 2 on each homologous chromosome. And we actually do need to be mindful of this difference between the alpha genes and the beta genes, because this is going to be an issue when we learn about thalassemias. Each polypeptide, of course, has a single heme. Heme consists of 2 parts, a porphyrin ring, and in the center is the iron atom. The iron needs to be in the +2 state in order to carry oxygen. It will be the polypeptides, the alpha chains and beta chains, that are going to direct the binding and release of oxygen. This needs to be reversible binding. That means oxygen needs to bind to the heme in the lungs and then be released in the tissues. Without these polypeptide chains, the iron would bind irreversibly to oxygen and it would never let it go. Its affinity for oxygen would be way too high. Looking at this picture, we can see a molecule of hemoglobin can transport 4 molecules of oxygen. Now let's look or review the globin chains again. I said on the previous slide that it's the globin chains that will direct the affinity of iron for oxygen. And these are products of genes. Chromosome 11 has the copies for the beta globin genes. There are 2, 1 on each chromosome. Chromosome 16 has the copies for the alpha globin chain. There are 4 genes, 2 on each chromosome 16. But this is not the only hemoglobin molecule that we express through our life. There is actually an embryonic hemoglobin and a fetal hemoglobin. The embryonic hemoglobin has the same alpha-2 polypeptides, but it uses a product of a different gene, the epsilon gene, for the epsilon subunits. And this creates the embryonic hemoglobin, alpha-2, epsilon-2. Alpha-2 gamma-2 describes the fetal hemoglobin, which is synthesized from 3 months until just shortly after birth. Now, again, it still uses the alpha subunits, but it will use different genes that code for the gamma globulin chains. The adult hemoglobin, of course, is the traditional alpha-2, beta-2. Now let's put some things together. During the embryonic period, hematocrit is occurring in the yolk sac. The type of hemoglobin being used at this time is synthesized as alpha-2 epsilon-2. This has a very high affinity. I'll remind you, at this stage, the blood vessels in the embryo are not formed yet. Therefore, simple diffusion is the only way that embryo is going to get oxygen to go from the mother's bloodstream through the uterine lining and into the embryo. Therefore, the embryo needs to have a very high affinity for its hemoglobin in order to take the oxygen from the mom's blood. But once the embryo transitions into the fetal state, now there are blood vessels, and certainly there is the umbilical cord and placenta in place. Now fetal blood and maternal blood are transporting gases very closely together in a countercurrent fashion. The fetus still needs to have a hemoglobin with a higher affinity than the maternal adult hemoglobin. So the oxygen will then diffuse from the maternal blood into the fetal blood. Then finally, within 6 months of birth, the baby will transition from fetal hemoglobin to adult hemoglobin, because the fetal hemoglobin has a higher affinity than the adult. And the baby, now that it's breathing oxygenated air, does not need that high affinity. Perhaps this word affinity is a new term for you. Well, I'm going to review very quickly our oxygen hemoglobin dissociation curves on the next few slides. Looking at this slide, I want you to realize that iron can wiggle within the porphyrin ring. It can be in a relaxed state or in a tensed or tented position. You see, when iron is in a more tensed position, it's not going to be able to bind to oxygen as readily. Think of it as it flicking oxygen away. But when iron goes into a more relaxed position, it moves more inferiorly into that porphyrin ring, and it can bind to oxygen. And when this happens to one iron, it will actually facilitate the movement of the other iron atoms in the other 3 globin chains to move more inferiorly into this relaxed state. It's the relaxed state that can bind oxygen. So what we're going to see is, with the progressive loading of oxygen, it's actually going to help the other iron centers in the other adjacent polypeptide globin chains to also bind to oxygen. This is something called an allosteric interaction, and it explains the curve in the oxygen hemoglobin dissociation curves I'm going to show you. Additionally, I'm going to remind you that there are some factors that can cause a shift in the oxygen hemoglobin dissociation curve. When the curve shifts to the left, it will reflect hemoglobin holding on to oxygen more tightly. In other words, hemoglobin's affinity increases. Again, the iron is moving more inferiorly into that relaxed state, and this means it wants to hold on to oxygen. When we see a shift to the right, it's going to reflect that hemoglobin has a reduced affinity for oxygen. That means the iron is going to poke out of that porphyrin ring and go into a tensed position. It is going to be more likely to give off that oxygen. Let's begin with a simple dissociation curve. First of all, I told you that fetal hemoglobin has a higher affinity than the maternal or adult hemoglobin. Here you can see the left shift of the fetal hemoglobin. If you look at, say, 40 on the x-axis, it represents 40 millimeters of mercury. This is 40 millimeters of mercury worth of pressure. This is the pressure that we would typically see at the venous side of a capillary bed. At the arterial side of a capillary bed, we have 100 millimeters of mercury. So if we look at the 100 value on the x-axis and draw a vertical line up until that line intersects the fetal and maternal hemoglobin lines, you'll see that for both types of hemoglobin, they would be 100% saturated. But now if you go down to 40 millimeters of mercury and draw a vertical line up until it intersects the maternal and fetal hemoglobin lines, you'll see that the maternal hemoglobin is now 75% saturated, but the fetal hemoglobin will still be about 90% saturated. This reflects the maternal hemoglobin being more willing to give up one oxygen molecule, going from 100% down to 75% saturated, means we went from 4 molecules of oxygen bound down to 3. The interesting thing between fetal and adult hemoglobin is that we see these molecules behave differently in a test tube versus in vivo. In a laboratory, if we were to isolate fetal and adult hemoglobin and put them in a test tube and monitor their affinity for binding oxygen, in a clinical setting, they technically have the same affinity. But in vivo, inside a red blood cell, inside a body, they have different affinities. And the question is, what's going on inside the red blood cell versus in that test tube? The answer is, when the hemoglobin is found intact inside the red blood cell, there are other solutes in the cytoplasm that are affecting the affinity for hemoglobin. The other solute I'm going to refer to and show you on the oxygen dissociation curve is this solute called 2,3-bisphosphoglycerol, and I'll show you that in just a minute. In other words, the presence of 2,3-BPG, sometimes it's called diphosphoglycerol, so 2,3-DPG. This 2,3-BPG has greater effects in the maternal or adult hemoglobin and causes it to have less affinity than the fetal hemoglobin. As I said before, there are many changes in the body that can alter the oxygen hemoglobin dissociation curves. pH is one of them. Shown here in red is a typical pH and CO2 value. In the green, you are seeing a left shift. In blue, you are seeing a right shift. I'll remind you that the right shift means there is less affinity for oxygen. So for any given change in partial pressure, that right shifted hemoglobin is more willing to give up the oxygen. The left shift, shown in green, shows you that for any given change in oxygen partial pressure, that hemoglobin is less likely to give up oxygen. Focusing on the right shift, shown in blue here, you see there is a reduced pH and that the hemoglobin is more willing to give up oxygen. When might a tissue bed have a reduced pH and do such a thing? Well, when the tissues are more metabolically active, they would be generating more acids, and this would cause a reduction in the tissue pH. This means that the blood traveling through the capillary bed that serves this tissue would be more likely to give up oxygen then. That makes sense because if the tissues are more metabolically active, they probably need more oxygen. So it's the tissues themselves that are going to be creating an environment that dictates how much oxygen is dropped off to them. In other words, the tissue's metabolic rate is dictating how much oxygen they need. And it's a perfect setup because then, if they are more metabolically active, then they create more factors that would cause a right shift in hemoglobin. If they are less metabolically active, then those factors will not be produced, and therefore the hemoglobin will experience a left shift where the iron is in a more relaxed state and has a higher affinity for oxygen and less likely to give it up.